Hello, everyone. Welcome to this virtual tumor board. It's a pleasure to bring together international faculty to discuss these cases. Before we get started, we'll just do a round of introductions. I'm Dr. Benjamin Levy, and I'm Associate Professor at Johns Hopkins School of Medicine, a thoracic medical oncologist. I am joined here today by, again, a fabulous international group of physician scientists. We'll start with Dr. Sanjeev Bala. You want to introduce yourself, Dr. Bala?
Yes, hello everyone. My name is Sanjeev Bala and I run the cardiothoracic radiology division here at the Mallinckrodt Institute of Radiology at WashU in St. Louis. Nice to be here.
My name is Wally Kern. I'm the executive director of Winship Cancer Institute here at Emory University and chair of the Department of Radiation Oncology.
Hi, Dr. Levy. I'm glad to be here. I'm a professor of surgery and a thoracic surgeon at the Washington University in St. Louis.
So I'm Dr. Mark Socinski. I'm a thoracic medical oncologist and the executive medical director at the Advent Health Cancer Institute in Orlando, Florida.
Great. So let's get started. This next case is a 71-year-old male with extensive stage small cell lung cancer, completing 4 cycles of carboplatin, etoposide, atezolizumab. Patient was most recently on maintenance atezolizumab, but unfortunately has disease progression. And not surprisingly, he's a former smoker with 80-pack-year history. And we'll talk about potential next lines of therapy or lack thereof for a patient on chemotherapy, immunotherapy. So patient presentation, this is a patient who presented with a cough and shortness of breath in April 2020 with no new symptoms. He has an ECOG performance status of 2. His past medical history is consistent with hypertension, coronary artery disease, CKD, and mild chronic obstructive pulmonary disease, or COPD. He, not surprisingly, again, has an 80-pack-year history of tobacco use. He quit in 2005. He does not have any alcohol or illicit drugs. He has no significant family history for lung cancer or any other cancer history. So I mentioned to you that he presented with a cough and shortness of breath in April 2020. We will review now his initial CAT scan that was done because of this cough. So Dr. Bala.
Thank you, Dr. Levy. So we've got the lung window from his CT, which shows all these little lucent holes, which are in keeping with his emphysema or COPD. And then you can see that there's this right middle lobe mass, which measures about 4 centimeters. And as a rough guide, what's always nice is the vertebral body is about 4 centimeters. So you can always use that as an internal ruler. The cut that we have through the upper abdomen shows innumerable metastases throughout the liver. There are these ring-enhancing lesions that are present in all 4 lobes of the liver. And so this is just an unfortunate good look for metastatic disease to the liver. What we don't have shown on these images are that there were some osseous metastases as well. There's a suggestion of that on the vertebral body from the upper abdomen. And there was a subsequent PET, which we don't see, which showed that there was some lymphadenopathy in the hilar and subcarinal regions. But solid lesion in the right middle lobe with metastases in the liver, probably the bone, and with ipsilateral lymphadenopathy and subcarinal lymphadenopathy.
Great. Thanks, Dr. Bala. So the diagnostic workup, the imaging, not surprisingly, many of our patients with small cell present this way: 4 centimeter right middle lobe mass, a PET scan confirming the right middle lobe mass, right hilar nodes, and in this, as mentioned by Dr. Bala, innumerable liver metastases with widespread osseous metastases. I wish this wasn't the initial presentation for our small cell patients, but more often than not it is. The patient has a MRI of the brain that is negative, has a liver biopsy. The biopsy of the liver is consistent with metastatic small cell carcinoma, CD56 positive, chromogranin positive, synaptophysin positive. And the labs that the patient has are most consistent with a mild anemia. It's a slight elevation of creatinine with normal liver function tests, despite the widespread disease in the liver. So the patient gets chemotherapy with carboplatin, etoposide, and atezolizumab for 4 cycles. My assumption is that a CAT scan is done after 4 cycles and shows either a response or stable disease. So the patient is then a candidate for maintenance atezolizumab based on some newer data. But the atezolizumab is continued after 5 months in December 2020. The patient's also getting zoledronic acid, and we can certainly talk about differences in bone strengthening agents for our patients with non-small cell and small cell. But the patient is discontinued on the atezolizumab and ends up getting imaging done at that time. There's a reason the patient's discontinued, and I think we're going to.
So you can see from the single image here, the number and sizes of all these liver metastases is increased when we compare to the prior study. So there's been a progression of hepatic metastases, and not shown is that there's also been a progression of some of the osseous metastases as well.
So again, not surprising, unfortunately, as an unforgiving disease, small cell. So the CT chest, abdomen, pelvis, as mentioned by Dr. Bala, shows increased size and number of hepatic lesions, also increased bony metastases. So I want to talk first just about the treatment options for small cell lung cancer patients in the treatment naive setting. So Dr. Socinski, you agree with the regimen used initially, and are there other competing regimens that can be used?
Yes, I think the Empower 133, which established the grafting of atezolizumab onto our standard platinum etoposide chemo combination, makes this a perfectly reasonable option. The other option we have in the first line setting is based on the Caspian data with durvalumab. To me, those look like Coke and Pepsi in terms of the outcome of that. People have their favorites and preferences, but I think there are actually two standard of cares in that particular setting. I do limit my treatment to 4 cycles of the cytotoxic portion, and then do continue maintenance therapy with the immunotherapeutic agent by itself.
And does it matter, do you use PD-L1 for small cell, or is that just, we don't use it like we do in non-small cell?
No, we don't. I mean, it hasn't, looking at it, it doesn't have any predictive nature to it. It's hard to measure. We often have poor quality biopsy specimens in small cell. It was not a requirement of any of the pivotal phase 3 trials. They did look at a subset of the patients that might have had PD-L1. It didn't seem to be helpful in this particular disease setting.
Okay, so this patient, unlike many of our patients, gets chemo with immunotherapy, with maintenance immunotherapy, and then develops disease progression in the liver and in the bone. The answer to this question, I'm sure, has changed for you probably, based on recent data. It may have changed again, but we've had some new therapies approved in the second line for small cell lung cancer. We have a phase 3 trial that shows that maybe it's, not that beneficial. What's your go-to regimen in this setting, and why?
If you look at the NCCN recommendations in this setting, I think there are 13 different drugs that are listed, including bendamustine, based on phase 2 data. The initial approved drug was topotecan. Topotecan does have both an IV and oral formulation. Many times I have, because I find this an incredibly palliative setting, I think there's some value in oral therapies in this particular setting based on this relatively unfavorable schedule of the IV topotecan. Recently, we had a drug, lurbinectedin, that was approved on a 105 patient cohort of a larger study that did show activity. I have no doubt that it does have activity in this setting. However, I'm not sure it has more activity than a number of the other agents that are listed on the NCCN recommendation. So I don't think there is one clear drug that stands out in this setting. I'm concerned that 5 months on maintenance therapy, he has a liver that looks like that. And I think this is a very, very clinically extremely difficult situation for us medical oncologists, because we really don't have a lot of tricks in our bag, so to speak.
Is there ever a discussion with these patients? So if this patient, if you had to choose one, I know it's really a nuanced decision based on everything we know about, this setting. What would you go with?
I probably in this setting would use lurbinectedin based on the recent data. And my rationale for that is, I guess we would call him sensitive relapse because he was more than 3 months. In that subset, if I remember, correct me if I'm wrong, Ben, I think the response rate was 45% in this setting. And the reason I choose that, it's a 1-hour infusion once every 3 weeks, so it's pretty simple. I think the toxicity of it is relatively straightforward. It behaves kind of like an alkylating agent. So I'm not too concerned about managing the toxicities in this setting. And so I think that probably would be my go-to in this setting.
Yeah. And do you have, looking at that liver, looking at this patient, is this a time for palliative care discussions, or, is that even a consideration?
Yes. I mean, I'm fortunate enough to have a palliative care physician who shares my clinic day. So this is the type of patient that I would introduce before I started first line therapy. And so they would have a relationship. But yeah, because this, as you well know, this is not an unusual course for a small cell patient. I mean, this we see this all the time. And so we have to be prepared for this. Sometimes it occurs a little later, sometimes a little earlier, but for the most part, an extensive stage disease with liver involvement at the initial diagnosis, this is a very typical scenario.
Yeah, and I echo some of the things you stated, just getting the palliative care team in early on these patients. I think we know the earlier you get them in, small cell or non-small cell, the better off these patients do in terms of quality of life, in terms of, and more importantly, survival. So it's a good point to get the palliative care team in sooner rather than later. Let's just offer a few scenarios here that are a little different, few different nuances here. Let's say that instead of, would it change your management at all if what we saw is that the liver disease was stable? This doesn't happen that much, but I'm just throwing it out there. Everything in the liver is stable, but you have progression in the lung locally. So essentially all sites of disease are stable, with only one area in the lung growing, biopsy-proven small cell. Dr. Curran, is there a role for palliative radiation in a sort of an oligometastatic, not oligometastatic, but a progression of one side of disease in the otherwise stable small cell? Is this a consideration for radiation?
I think in a very highly selective way. If it was a small volume area where you could do a stereotactic or hypofractionated regimen and complete a course with a few fractions, sure. I would not submit this kind of patient to a 4 or 5 week regimen. I don't think it's the best use of their time, to be honest.
Okay. And finally, just the second scenario briefly, Dr. Puri, there's a lot of controversy about the role of surgery for very early stage small cell lung cancer, node negative small cell lung cancer. And I just put the picture back up here. You've got a right middle lobe mass. Let's say it's biopsied, it's small cell. Let's say the PET scan is negative in the hilar and the mediastinum. Let's say an EBUS is done and you've done everything you can to prove that the nodes are negative. Is this in a fit patient? Is surgery something? Is it in the calculus for these patients for early stage small cell lung cancer?
Thanks, Dr. Levy. For patients with T1 or T2 N0, and that should be, like you pointed out very closely, should be histologically N0 mediastinum, there is definitely a role for surgery. Most of these data come from either single institution retrospective studies or large analyses of data sets such as the National Cancer Database or the SEER Medicare database. And they obviously show selection bias in the patients that undergo an operation, but these patients who are otherwise fit for surgery and have T1 or T2 N0, they should be candidate or considered potential candidates for performing lobar resection. So when all of these retrospective studies, they compared matched patients who underwent a sublobar resection versus undergoing a lobectomy. The long-term survival in the lobectomy group was significantly superior to the patients who underwent either a segmentectomy or a veg resection. In this particular individual, since the lesion is in the middle lobe of the lung, and that is actually anatomically the smallest lobe of the lung, if one would have no evidence of mediastinal disease and an otherwise healthy patient, then surgical resection in the form of lobectomy would be a good discussion to have.
Great overview of the potential role for limited stage small cell lung cancer, early stage or limited stage. Just quickly to Dr. Socinski and Dr. Curran both, let's say a resection is done. Would you offer adjuvant chemotherapy, Dr. Socinski, and Dr. Curran, would you offer PCI?
I have offered, my training is that small cell and non-small cell should be managed probably similarly based on TN and M staging. If you have, as Dr. Puri points out, if you have a node negative small cell, we don't see those very often, but in an otherwise fit healthy patient who can undergo surgery, I think the right thing to do is to resect, stage intraoperatively as well as preoperatively. If it is node negative, my practice has been based on, again, the literature, but the literature is, there's no randomized data. It's just what people have done. And many of these patients have survival rates that seem to be much better than we see with the typical limited stage small cell chemoradiotherapy data, where we think we cure roughly 30% of those patients. So I would recommend 4 cycles of adjuvant cis etoposide in a patient like this if they were resected and had small cell.
Dr. Curran, your thoughts on PCI for limited stage small cell treated with concurrent chemoradiation and limited stage small cell or early stage node negative small cell that's resected?
Yeah, so I think there's a good randomized data in either type of limited stage small cell to use PCI, whether the treatment was chemoradiation or resection and chemo. I don't subscribe to the idea that it's a standard approach to extensive stage disease. The only extensive stage patient I would consider would be someone who just was beyond the strict parameters of limited stage, perhaps a limited stage patient with maybe one side of metastatic disease where you went ahead and did chemoradiation, was in a CR. That would be the only extensive stage patient I'd consider for PCI.
Great. Well, this is
Dr. Curran, Dr. Curran, Dr. Rosenman used to call those limited extensive stage.
Exactly. L-hyphenemic.
This has been a great discussion on extensive stage small cell lung cancer and some scenarios with limited stage small cell.